Hi everyone, I'm Ariel Celia, behavioral scientist, recovering academic, and now consultant in tobacco harm reduction. My disclosures are up on the screen, but this is my personal channel and it's not funded or overseen by my employers or clients. Today we're going to talk about why almost all of the studies on dual use of cigarettes and e-cigarettes that you might have heard about are wrong. The motivation for my video is that in the past week alone, there have been several new papers published on PubMed that all have the same fundamental flaws. So here's one on adverse respiratory symptoms among e-cigarette users. Here's one on smoking cessation, tobacco product type, which means e-cigarettes, and depressive symptoms. Here's one on associations with mental health. Here's one on post-operative complications following ankle surgery. Here's one on substance use and mental illness and mental health treatment utilization. Here's one on oral health related outcomes. I should mention that this is a review article, not a primary source article, but that almost makes it worse because it's drawing from several underlying studies that all have the same fundamental flaws. Same here, another review study that looks at endothelial dysfunction and erectile health. Again, a review study, but draws on underlying studies with the same exact flaws that I'm going to talk about today. 7 studies all in 1 week. You can imagine how this accumulates over the years. There have got to be close to 1,000 studies on dual use or e-cigarette use looking at some health outcome. This is a type of study, in my mind, after weekly reviews of the literature for several years now. This stands out as its own study type. They all have the same characteristics. They analyze observational data. It's usually cross-sectional data from a national health survey, but it doesn't have to be. Sometimes it's a custom online survey that they conduct that's cross-sectional. In rare cases, it's longitudinal, but even the longitudinal ones might still have the problems that I'm talking about today, which I'll go into later. The next characteristic is that once they start with observational data, they then group participants by what products they happen to be using at the time. Usually this is a 4-category predictor variable with non-use versus exclusive vaping versus exclusive smoking versus dual use of both products. And all of this is defined in the past 30 days in terms of what they happen to be doing in the past month when the survey was administered. Next, the analysis is basically comparing some health outcome across these groups. And in these large national surveys, they have a whole list of health outcomes, especially something like NHANES that has many, many different types of questionnaires asking about every possible kind of medical outcome. So this is a prime topic for groups that like to do salami publishing, where they essentially do the same research but then slice it different ways. So in this case, certain research groups can just go down the list of health outcomes in one of these surveys and try to publish a different paper using the same structure, same flaws, but just swap out the outcome. And finally, they blame any differences between the groups on vaping. So in the case of dual use, this is usually found to be higher risk of whatever health outcome than exclusive smoking. And if there's a difference there between where dual use is worse than exclusive smoking, or even if exclusive e-cigarette use is worse than non-use, it's blamed on vaping. And in the case of dual use, it's blamed on a synergistic effect of vaping. So in other words, it's bad. They're attributing the health effects to the addition of vaping to smoking. Why is this a problem? It's the same flaws over and over again in all of these studies. You saw the list of different health outcomes that were examined just this week, but fundamentally it's the same type of paper with the same flaws over and over again. These are 4 flaws that I'm going to explain today. One is the apples to oranges comparison, where you're comparing these different groups based on their product use, and you're attributing the differences to product use when there might be other differences between the groups to begin with. Second is confounding by smoking history. 3 is poor capture of dual users and transitions in some of these studies. And the last one is unclear and possibly reverse directionality of the association. Starting with the apples to oranges flaw. Let's focus here on the difference between dual use and exclusive smoking, because that's the most contested one right now in the literature. Most analyses, what they do, so you have, hypothetically, you're following people over time, right? So some people can just exclusively smoke the whole time. They never try e-cigarettes. They never become a dual user. But let's say someone becomes a dual user and adds, so they're now like increasing their total exposure. They're adding vaping to the baseline level of smoking that they were already doing. But the other possibility is that they're gradually replacing some of their cigarettes with vaping. So in that case, they would reduce their CPD, means cigarettes per day. They would reduce their cigarettes per day, but they'd still be a dual user. But it really matters where they started from, right? So most of these papers compare exclusive smokers to dual users. And if they find a difference, they say, oh, oh my God, that's because of e-cigarette use. It's because of a synergistic or additive effect of vaping. But they don't bother to ask or consider whether the person started from an even higher baseline or whether they added. A lot of the literature is kind of assuming that e-cigarette use is additive to dual use, but that might not be what's going on. So that's the one problem. And this kind of leads into the second issue, because I illustrated the apples to orange difference here with a pre-existing difference in cigarettes per day. So in other words, the people that go on to dual use have higher cigarette consumption to begin with. That's one possible difference. There might be other differences too. There's probably age differences, because older age groups tend to not be interested in trying e-cigarettes. And of course, age is associated with health outcomes. So there's all sorts of different possible confounders that could be different between people that self-select into the dual use group versus people that self-select into continued exclusive smoking. And this leads into confounding by smoking history. Most of these studies on dual use, the type that I'm talking about, if you read the abstract, or if you read, even sometimes if the author appears in the media talking about the study, they'll claim to adjust for smoking. So if you don't think too closely about that, you might think, okay, well, they adjusted for smoking, so therefore any difference is more credibly due to vaping. But really what this means when they say they adjusted for smoking is that they adjusted for smoking status, meaning they have just a very crude variable in the model for whether they currently smoked, former smoked, or never smoked. But that's not what matters for health outcomes. It's the cumulative exposure over long periods that matters. So for lung cancer screening, for example, you have to have 30 pack years, which is the equivalent of smoking a pack a day for 30 years. In order to elevate your risk of lung cancer enough to warrant screening for it. So the long exposures and the heavy consumption is really what matters, and that needs to be controlled for. This is a paper supporting this, where this is actually a very carefully done study on dual use, where they kind of did the basic comparison I'm talking about first, and then they compared how the results differ when you also adjust for pack years and cumulative smoking history. And they found out the apparent association that was being blamed on vaping actually goes away once you account for cumulative smoking history. So it's really important to do that, but almost no studies do that. This figure is kind of a critical summary of a different paper that does a meta-analysis on some of these health effect studies. And they found that very few of them control for cumulative cigarette smoking duration. And the result of failing to control for this is that lingering or even ongoing effects of cigarette smoking are being blamed on vaping. The third issue is a little more complicated to explain, so bear with me. A lot of these studies are based on national survey data that are done every year or every other year and sample a different group of adult participants every time. The problem with this is that there's a bias in the capture of dual users. So what do I mean by that? This is a color coding bar where red means cigarette smoking, yellow and orange mean that you're cutting down and kind of gradually transitioning to e-cigarettes, and then green means switch to e-cigarettes. So this is like a schematic of just somebody's trajectory as they go from exclusive smoking to a transitional period of dual use, and then to exclusive vaping. So that's one person. Now take many such people who might start dual using at different times. So like, let's look at the timing of the orange when they started dual using. So they're like starting out on their transition journey by adding e-cigarettes. And that can happen at different times for different people. if it's just kind of a population cohort study. And they might dual use for different lengths of time. Some people might switch almost immediately, while others might be in a more gradual transition stage where they slowly taper down their cigarettes and slowly transition their nicotine consumption to vaping. So different lengths of time, they start at different times. What happens in a national survey is that you have this arbitrary time of the survey that it has no relationship or no bearing to people's individual trajectories if it's just a population survey. It's different, by the way, if it's running like a randomized controlled trial or you're like recruiting participants into a new study at the time that they start using dual use. That's a better study design for what I'm talking about. But most of these cross-sectional studies that analyze national survey data have this problem where the time of the survey has no relationship to when they started their dual use trajectory or where in that process of switching they are. So this person would be categorized as an exclusive vapor. This one would be categorized as a dual user, etc. And it might even get some people that don't start until after the survey. If you're one of the quick switchers, so let's say this case up here, and you're green, so you're switched to e-cigarettes completely by the time the survey comes along, you're not going to be considered a dual user because the survey defines what you were doing in the past month at the time of the survey. So this person would be an exclusive vapor. Their prior dual use doesn't get counted at all, so they kind of fall through the cracks even though they're a success case. Whereas somebody that is, for lack of a better word, stuck in a dual use state for a while, they're more likely to get flagged as a dual user because the survey comes along and it's easy, and there's more of the year for the survey to be administered to them while they're dual using. And the problem is that this isn't randomly occurring across participants. It selects for people that tend to be smoking for longer and have a heavier smoking history and maybe are less likely to switch in the future. So national surveys like this that just have a cross-sectional population survey tend to be oversampling people that get stuck in the dual use state and are already worse off in other ways. So you can see how this further biases the apples and oranges issue because you're selecting for people that are already worse off, and you're failing to catch the people that switched quickly and might have improved their health pretty quickly from switching to vaping. The last issue is uncertain or even likely reverse temporality. So most studies, especially if it's a cross-sectional national survey, they don't have any information on when vaping started relative to the disease onset or the health condition onset. In fact, it's actually likely that the reverse is occurring, especially for age-related diseases like COPD. This really insightful paper by Brad Radu analyzed the PATH dataset, which is longitudinal, and it has a lot of details about the age that they first developed COPD and the age that they started vaping. And you can see almost all the participants are in the bottom triangle of this matrix, which means that they were older when they started vaping than they were when they developed COPD. So this is a reverse causality problem. There's only a handful of people that pretty clearly were vaping first before they were told they had COPD. And then along the diagonals, you can't really know. It's in the same age bucket, so you don't know which one came first technically. But certainly the bulk of the participants here started vaping well after they developed COPD. And there's still an association here, so it's another situation where the association is misinterpreted and blamed on vaping when it's really, if anything, maybe reverse causality. If people are suffering from their COPD, maybe that motivated them to switch to vaping to improve their symptoms. So that's a case of reverse causality, but it's being interpreted as e-cigarettes causing COPD when it's more likely that COPD was already there and may have caused the vaping. Cross-sectional data are the worst for this, but even longitudinal studies are not immune from this. So you could imagine with this PATH study, you can measure e-cigarette use at wave 3 and then COPD at wave 4. But if you don't specifically eliminate the people that already had COPD at wave 3, then it's just as bad as a cross-sectional study without that information. Most studies of PATH do not go through the effort to remove people that already had the condition at baseline or might have had relevant symptoms at baseline. And this is a severe issue, right? This was severe enough to cause a retraction of a paper on heart attacks in 2019 based on the potential of reverse causality. But unfortunately, the same flaw still remains on the scientific record in hundreds of other studies. So wrapping this all up, if you're a consumer of the research, especially if you see something in the news that sounds alarmist, these are the questions you should be asking yourself about the study. Are the data longitudinal? And if so, is the outcome new onset of disease as opposed to disease or symptoms that might have existed from the beginning? Is smoking history accounted for? And I'm talking about things like pack years, cigarettes per day, years of smoking duration. If they quit, how long have they been quit? Not only smoking status, that's not sufficient to account for the cumulative or lingering effects of smoking history. Are the results shown separately for current, former, and never smokers? This is important because since there is so much confounding by smoking history, another way to look at that and possibly get around the confounding is to look especially in never smokers, but you have to reason that if vaping is having a causal effect on the health outcome, then you should observe that effect regardless of whether they never smoked, formerly smoked, or currently smoked. If there's a big difference in the effect of vaping by smoking status, that probably means there's still confounding by smoking status. Next, did authors specifically drop people from the analysis who switched to vaping after they developed the health condition? If not, then there's reverse causality. And so if the answer to any of these questions is no, the results are almost certainly biased against vaping. It doesn't mean that vaping has no effect. It's hard to prove a negative like that, but you can be pretty sure that there's at least some bias against vaping, where there's a pre-existing difference, probably due to smoking history or other differences between the groups that are being blamed on vaping, and how much is unclear. My tips for researchers who are involved in dual use is it's really key to follow people from the start of dual use. Relying on national survey data doesn't really cut it unless you try to do a careful job of measuring smoking history and trying to capture people who might have dual used and switched or gone through another transition before the start of the survey. You should also be adjusting for detailed measures of smoking history. Again, things like pack years, how many years have they been smoking, how many cigarettes per day, and if they quit, how long have they been quit. All of these things correlate with health outcomes, and they're really important to take into account. Even then, it might not be sufficient to completely separate that from the effects of vaping, but it's a start, and in a lot of cases it's shown to explain the effects that were previously interpreted as vaping were really due to smoking history. Next, stratify analyses by the smoking status. So again, it's the idea that if e-cigarettes do have a causal effect, you should be observing that at all levels of smoking status, regardless of whether somebody never smoked, currently smoked, formerly smoked. It's the consistency across these levels that supports any attribution that you're trying to make. Next, you should drop people who had the health condition before starting to vape, or maybe even pre-existing symptoms. And I've seen that in some of the respiratory studies. So sometimes if they look at COPD outcomes or asthma outcomes, it makes a difference whether you include or drop the people that were having perhaps undiagnosed respiratory symptoms at baseline. So you want to rule out anything that could be a pre-existing condition. Finally, there's a tendency in the literature to publish something anyway, regardless of how many flaws it has. And there's an idea that if you just list all the flaws in the motivation, like, oh, you can't conclude causality, you can't rule out confounding, there's a thinking that that's enough to just acknowledge it in the limitations of the paper. That's not enough. There's a lot of papers out there that are honestly doing more harm than good, scaring people away from trying a safer product because they're taking these confounding effects, like lingering effects from smoking history, and blaming it on vaping. Researchers need to be a lot more responsible about what we publish. We have to think, is it doing more harm than good? Is it giving the wrong impression? Are the flaws of this study so severe that it makes the result that I'm finding wrong or completely inconclusive? And dual use is a popular topic in the literature right now. I have seen more acceptance in the research community that e-cigarettes are a valid form of harm reduction for people that otherwise would have kept smoking, but that hesitation has now shifted to dual use. So the concept of dual use is really timely and important in the research, and we really need to strengthen the quality of the research on dual use. Thanks for your attention. Any comments, experiences with dual use, I'm happy to hear them in the comments. And as always, let me know if you have any suggestions for future topics. See you next time.